PSN to a Group 3 presentation. Members 1. Lopez, Gorilla Velta, Listen, Grits T3, Mendoza, Renalyn G4, Mission, Brian John G5, Mesa, Christine D6, Mendoza, Karishme H7, Maulana, Mohammed Ayabay 8, Garsuda, Alan Draw, Najampayas, Ricky JRP.
Hello everyone, I am pleased to share with you information about Cogan syndrome. Cogan syndrome was described by an ophthalmologist, David Cogan, in 1945. He reported the 4 observations of non-syphilic interstitial keratitis, which is associated with vestibulo-auditory dysfunction. So, Cogan syndrome is a rare autoimmune disease that affects the eyes and the inner ears. The symptoms include irritation and pain of the eyes, decrease in vision, hearing loss, and vertigo. Other symptoms may occur like muscle pain and inflammation of the blood vessels. The exact cause of this disease is not yet understood by the researchers. It is thought that the cause of this disease is the auto-response that led the immune system to attack the tissues of the ears and the eyes. In other words, when the body's natural defense mistakenly attacked the healthy tissues of the eyes and the ears. In addition, Cogan syndrome is known that this is not run in a family. It occurs in all ethnicities. Diagnosis is based on the symptoms associated with the syndrome. In 1945, there are only hundreds cases are reported in the literature, and the tissue pathology is remain unknown.
Ate? Uy! Ate! Ate! Mama! Si ate! Uy, ate! Ate! Uy!
Anak! Anak!
Ate! Uy! Uy! Ate!
Anak!
Uy, ano ba?
Kagayin mo siya, dali natin siya sa hospital.
Assessment. Subjective data. Laging sumasakit. Ang motoko at pang. Nabibingi ako. As verbalized by the patient. Objective data. Tinnitus. Cornea and inner ear. Inflammation. Fever. Weight loss. Blurred vision, hearing loss, fatigue, nausea and vomiting, restless, vertigo. Vital signs taken as follows: temperature 38 AC, blood pressure 140/90ths mmHg, pulse rate 90 bpm, respiratory rate 15 bpm, Ophthalmologic results. 5/10 LE and 6/10 RE.
Nursing diagnosis: pain related to presence of eye inflammation and inner ear dysfunction. Disturbed sensory perception related to altered status of sense organ. Planning or desired outcome. For short term, 8 hours of nursing intervention, patient fever will decrease or return to normal range. Decrease or eliminate inflammations, eliminate nausea and vomiting, patient will have enough rest. For the long term, patient will have clear vision, will be able to hear clearly, pain-free, able to sleep or rest well, able to gain weight.
Intervention or implementation.
For the independent, monitor patient's vital signs. Perform TSB or tepid sponge bath. Advise patient not to touch the eyes to prevent irritation. Give medication prescribed by the physician. Provide safe environment for patient to avoid falls, fractures, and other injuries. Improve lighting levels but ensure there are no glare present. Reinforce the importance of adhering to treatment regimen and keeping follow-up requirements. Advise patient to have a proper therapy that may help for recovery. For the collaborative, administered corticosteroids as prescribed. Give the medication on time. Educate the patient about the treatment so that he can perform it independently. Encourage patient to report pain.
Cogan syndrome is initially treated with corticosteroids such as prednisone, along with medication that suppress the immune system to control inflammation. The generic name is the prednisone, and one of the brand example of prednisone is Deltason, under the classification of corticosteroid. The initial dosage of Deltason tablets may vary from 5 mg to 60 mg of prednisone per day, depending on the specific diseases entity being treated. The initial dosage should be maintained or adjusted until a satisfactory response is noted. If under a reasonable period of time there is a lack of satisfactory clinical response, Deltason should be discontinued and the patient transferred to other appropriate therapy. It should be emphasized that dosage requirements are variable and must be individualized on the basis of the disease under treatment and the response of the patient. Deltason chemical is synthetic pregnane corticosteroid and derivative of cortisone. The mechanism of action of Deltason is to decrease inflammation via suppression of the migration of polymorphonuclear leukocytes and reversing increased capillary permeability. It also suppresses the immune system by reducing the activity and the volume of the immune system. The indications of Deltason tablets are indicated in the following conditions like endocrine disorder, rheumatic disorders, collagen disorders, dermatologic diseases, allergic states, ophthalmic diseases, respiratory diseases, hematologic disorders, neoplastic diseases, edematous states, gastrointestinal diseases, nervous system, and miscellaneous. It is contraindicated to systemic fungal infections and known hypersensitivity to components. For patients' information, persons who are on immunosuppressant doses of corticosteroids should be warned to avoid exposure to chickenpox or measles. Patients should be advised that if they are exposed, medical advice should be sought without delay. General precautions. Drug-induced secondary adrenocortical insufficiency may be minimized by gradual reduction of dosage. This type of relative insufficiency may persist for months after discontinuation of therapy. Therefore, in any situation of stress occurring during that period, hormone therapy should be reinstituted. Since mineralocorticoid secretion may be impaired, salt and/or a mineralocorticoid should be administered concurrently. Corticosteroids should be used cautiously in patients with ocular herpes simplex because of possible corneal perforation. The lowest possible dose of corticosteroids should be used to control the condition under treatment. And when reduction in dosage is possible, the reduction should be gradual. Psychic derangements may appear when corticosteroids are used, ranging from euphoria, insomnia, mood swings, personality changes, and severe depression, to frank psychotic manifestations. Also, existing emotional instability or psychotic tenderness may be aggravated by corticosteroids. Steroids should be used with caution in nonspecific ulcerative colitis. If there is a probability of impending perforation, abscess, or other pyogenic infection, diverticulitis, fresh intestinal anastomosis, active or latent peptic ulcer, renal insufficiency, hypertension, osteoporosis, and myasthenia gravis. Growth and development of infants and children on prolonged corticosteroid therapy should be carefully observed. Kaposi sarcoma has been reported to occur in patients receiving corticosteroid therapy. Discontinuation of corticosteroids may result in clinical remission. Although controlled clinical trials have shown corticosteroids to be effective in the speeding resolution of acute exacerbations of multiple sclerosis, they do not show that corticosteroids affect the ultimate outcome or natural history of the disease. The studies do not show that relatively high dosage of corticosteroids are necessary to demonstrate a significant effect. Since complications of treatments with glucocorticoids are dependent on the size of the dose and the duration of treatment, a risk-benefit decision must be made in each individual case as to dose and duration of treatment and as to whether daily or intermittent therapy should be used. Convulsions have been reported with concurrent use of methylprednisolone and cyclosporine. Since concurrent use of these agents result in a mutual inhibition of metabolism, it is possible that adverse events associated with the individual use of either drug may be more apt to occur. Adverse and side effects of deltasol. Fluid and electrolyte disturbances like sodium retention, fluid retention, congestive heart failure in susceptible patients, potassium loss, hypokalemia alkalosis, and hypertension. Musculoskeletal effect like muscle weakness, steroid myopathy, loss of muscle mass, osteoporosis, tendon rupture particularly on the Achilles tendon, vertebral suppression fractures, aseptic necrosis of femoral and humeral heads, pathologic fracture of long bones. Gastrointestinal effect like peptic ulcer with possible perforation and hemorrhage, pancreatitis, abdominal distension, ulcerative esophagitis. Dermatologic effects like impaired wound healing, thin fragile skin, petechiae and ecchymosis, facial erythema, increased sweating, may suppress reaction to skin tests. Metabolic effect like negative nitrogen balance due to protein catabolism. Neurological effect like increased intracranial pressure, convulsions, vertigo, and headache. Endocrine effect like menstrual irregularities, secondary adrenocortical and pituitary unresponsiveness, particularly in times of stress, as in trauma, surgery, or illness. Suppression of growth in children, decreased carbohydrate tolerance, manifestation of latent diabetes mellitus, increased requirements for insulin or oral hypoglycemic agents in diabetics. Ophthalmic effect like posterior subcapsular cataracts, increased intraocular pressure, glaucoma, exophthalmos. Nursing responsibilities. Verify patient's identity before administer the drug. Assess patient history. Monitor patient vital signs. Consider the 10 R's in administering the medication. Report signs of discomfort or side effects. Advise patient to follow the prescription properly. Advise patient to report on the scheduled or follow-up checkup.
Evaluation. Short term. 8 hours of nursing intervention. Patient temperature back to normal. Inflammation eliminated. Patient looks well rested. Long term. Start gaining weight. Vision recovered. Hearing is recovering.